So Alex, that's great. Um, I, so Alex, we do have a couple of questions. Um, the first one, since MIG's targeting conventional outflow does not achieve the theoretical IOPs predicted by the equation, what is the explanation? Is it possible the equation's not entirely correct? Are we ignoring a possible contributor to one of the variables? Is it possible that resistance does not go down to zero? So, what are your thoughts there?
I mean, obviously, equations are intended to model true biology, and models can always be made more complex to really reflect what's going on. And the Goldman equation hasn't gone a ton of evolution over time, just really adding UV scalar outflow. And so it isn't enough because it's not explaining what's going on. So, okay, fine. Then what are the things that are possibly going on? One thought that I had been pushing was the idea of segmental outflow. It's where you place the trabecular bypass or the ablation matters. We still don't know if that's the case, but that could be one explanation. Another explanation could be that it's not just the trabecular meshwork, as we were speaking earlier with Dr. Charlazian about, MIGS plus meds. The distal pathway could still be contributing outflow as well in biological like pathophysiology and glaucoma as well, and that may need to be addressed. And so I do stand by my statement that theoretically, based on the Goldman equation, we should be doing better, and we're not fully understanding what's going on. I mean, things work, and so that's positive. It's good, but there's room to improve what we're dealing with here. And all of this is assuming that it isn't like the surgeon did a bad job or that the device got plugged. It's assuming that everything is actually working the way it's supposed to. We're still not getting what we should.
Yeah. And it's it's fascinating that all of a sudden now glaucoma treatment is concentrating back again in the trabecular meshwork, whether it's medications or these surgical procedures. So there's, another question. Do laser iridoplasties, since they create contraction of tissue towards the burn, affect pupil size? If they do, is the effect more in the light or dark?
So the answer is yes, but just, it's a matter of properly done and not going too crazy. So some practitioners, and I used to do this, would use an argon laser first on the iris to burn it and thin it out, and also potentially coagulate any potential bleeders, because you never know if you run into a big vessel, and then come later a second time with a YAG and then punch through because you've already eaten through part of the real estate and you handle bleeders. And I ran into a couple cases where, and in the olden days, actually with the argon alone, if you really go high blast and really like machine gun it, you could actually break through. And so I used to do that until I started noticing that on some of my cases, if I put a lot of argon in one place, I could get a peak to pupil just in that one little segment or quadrant. And I realized that, oh man, I think I'm being too aggressive. And so the reality is, yes, it can change pupil size anytime you use an argon laser. Okay. Now, what I described to you was not an iridoplasty. What I described to you was argon laser before an LPI. Iridoplasties typically use different settings. It's a much bigger spot size and it's a much higher power. But because the spot size is so big, it's spread throughout. So the image that I showed you was like a way extreme example for illustration to show you where it is and how it works. That's not the way it's supposed to be. Properly done iridoplasties, you see a little bit of shrink, and you really shouldn't see scar marks. And properly done iridoplasties, as opposed to argon before LPI, usually doesn't affect the pupil that much.
Great. One other question. With the advent of multifocal IOLs, clear lens exchange is being encouraged in narrow angle suspects, and the EAGLE study often refers to this. Is it going to become important to teach the subclass classification in narrows as you presented, and the importance of different management approaches for each? Thank you for these.
It's not like I'm creating new diseases. I didn't invent any new clinical entity. These are all the entities that have always been there that we should have learned all along. My narrows was just a way of how to organize it. And you don't have to learn it like that because people have done perfectly well in the past. But for me, it was an easy way to, put things in bins. And in particular, because these were bins that were actually just based on a slit lamp exam, which is why I really liked it, because everyone's got access to a slit lamp, but not everyone has access to the most advanced, imaging technology. And so if you're like, wow, this is insanely narrow, I've never seen anything like this, your mind should immediately go to malignant. If you're looking at high pressure and it's looking like a little narrow, but you're like, you know what, I could have convinced myself if this patient's pressure wasn't high, that it could have been a regular anterior chamber, then you start thinking about plateau, right? So the way that, kind of hang this is just so that it's easy to think about it.
Yeah, now that's great.
Hey, Alex, that was a great lecture. I mean, it was like a definitive lecture on angle closure. Thank you so much. I really appreciated your approach and summary for being consistent, following the Bascom Palmer guidelines for, iridotomy in the primary angle closure suspects. Someone else here brought up the aspect of when patients need to be dilated frequently, such as for diabetics and whatnot, and factoring that into the equation of when you decide to do prophylactic iridotomy.
That's true. I mean, it's kind of like a stepwise approach, right? I mean, for the most part, we know that they're diabetic coming in, but when I see the patient, especially for the first time, I'm just assessing the angle and I'm assessing whether or not they should get a laser. And then if I think they meet that criteria, for me, I will actually defer the dilation for the diabetic exam just to get the laser in, because it's only going to be a delay of a very short period. Now, of course, if they got something massive going on, their vision is hand motion, and you suspect something's really bad, you can always slip some OCT in there through a small pupil just to get an idea of what's going on. But for your typical, primary angle closure suspect, they're coming to you like, I'm just here for, a regular exam. There's nothing scary going on.
Thanks.
Yeah, no, great. The so another question came in, Dr. Wong, do you find more success with the Cahook than GAT as you're removing more TM tissue to prevent reclosure of the goniotomy? Any thoughts?
Well, so, I mean, this really hits on that whole leaflet idea, right? Because the Cahook gets rid of the leaflets, the GAT does not. All right. But at the same time, a couple of points here. Number one, it's not as if there's been a head-to-head study, so we don't know. Number two, they're not really apples to apples comparisons. If we're talking about the leaflet issue, you're really comparing Cahook to goniotomies. And in that case, the Cahook is better than the goniotomy. The reason why you can't perfectly and fairly compare a Cahook to a GAT is that the GAT does more than just the trabeculotomy. It also has the canaloplasty step in the surgery where you put the viscoelastic and the canal gets expanded. So the GAT's like doing additional things. And so therefore, it's not totally a fair comparison from a, if it's like a biological standpoint, which one makes more sense.
Yeah, no, great. So
Alex, are there going to be commercially available imaging devices that are going to help us with, deciding outflow issues and subconjunctival flow for our patients in the future?
So I have, a lot to say about that, way beyond our time, especially with, OCT. Let me just, I guess, tease as much as possible here. How often can you guys go through a half-day clinic and not get a single posterior segment OCT of the nerve? I could never do it. It's impossible. It's impossible. Okay. How many of you guys can go through a half-day clinic and not get a anterior segment OCT?
Oh yeah.
All the time. All the time. And so then you're kind of left with, wait a second, why? What's the problem? And okay, so there are actually a whole bunch of problems with anterior segment imaging. There are a lot, and let me just give you one really quick one. When you're doing posterior segment imaging of the macula or nerve, you're talking about like 1 millimeter of tissue. If you're talking about anterior segment imaging of the eye, let's say outflow, it's a 2 pi r, it's a circumference around the cornea. Radius is going to be like 6, so diameter is going to be like 12. So it's end up being like the circumferential length is going to be like 36 millimeters. Plus, to go from cornea to the back of the lens, it's going to be another 10 millimeters. So the challenge on anterior segment OCT that had always been unfair is that you're dealing with like way more anatomy. It may end up being that you cannot actually do anterior segment OCT for the entire anterior segment and ask all questions because you're dealing with too much depth and top like XYZ. And so there are other problems as well, but anterior segment anatomy, you already kind of know, doesn't quite hold a candle to posterior segment. And we need to actually fully understand the reasons why, and then what we're going for our various diseases before we can do what you're saying. And that's actually another talk for another time.
Perfect. We'll have you back.
That is. So, I would like to thank Alex. When I invited him, he never thought that he'd be in the midst of moving and doing all these other things at this time and taking time away from that. But it's always great to have Dr. Huang with us. I mean, his work is brilliant as a teacher. You really, take extremely sophisticated topics and boil them down.